and welcome to the Home of Medicine with me, Dr. Amie Burbridge, and
I'm Ben Lovell, key medical consultant working in London.
Fantastic. Okay, Ben, I've got a case for you today.
I'm ready.
And I'm going to set the scene because I love setting the scene. And I was in my first year of acute medical training as a registrar. Now, this might have seemed like a long, long time ago, but actually I had an interesting path to acute medicine in that I trained in rheumatology before I went into acute medicine. And I did a few years of rheumatology registrar before I then did a master's in med ed and finally found my home in acute medicine. Wow. So it was my first or my second week in acute medicine at quite a small district general hospital. And I was the on-call medical registrar. And I was referred a 66-year-old man from his general practitioner. And the only abnormality was abnormal urea and electrolytes. And a rash on his legs. And that was it.
So this must have been right up your street as a former rheumatologist then.
So what did I do straight away?
You did a urine dip and an autoantibody screen, a vasculitic screen, right?
So
I know how you guys operate.
Well, that's the thing. So what was happening with me then? What was I doing?
Okay.
You've just basically
and a rash.
Nailed the cognitive bias.
I was being slightly flippant. I know what you really did was you did a full assessment and you made a reasonable plan there. So you got someone with high urea, abnormal electrolytes, and a rash. Mm-hmm. So this is someone with a skin kidney issue. And skin kidney issues, when those two things go together, that opens a file in my brain called renal/rheum. And there's a lot of overlapping illnesses there. And I think there's actually millions of very subtly differentiated conditions which can go in that file, from vasculitic, autoimmune, glomerulonephritides, post-infective phenomena, loads of stuff. But I know that apart from doing your normal blood work and assessment, there are some extra things you guys are going to want to do, which is examine the urine and look to see if there's any autoimmunity going on. But starting from basics, you're going to take a history and examine the patient, and before you fill out your column of which boxes to tick on the blood form. So give me some info.
Okay, so 66-year-old man, fit and well. Bit of hypertension in his past medical history, but apart from that, nothing else of note really. So he went to his GP for like a well-man check. This was like 5 or 6. It's probably a bit longer than that actually. A few years ago, and GP did some routine bloods, and he was also on an ACE inhibitor. Therefore, so he had his urinary checked. So when the patient went to his GP, he had no symptoms at all, and he had no complaints. It was just a routine check. So when he came to hospital, his general practitioner had done a urea and electrolytes and found that his urea was elevated at 20. And they, within the UK, anything over 7 is abnormal, and his was 20. So pretty elevated. And his creatinine was 300 plus, and we're looking at 100 sort of for normal. So it was 3 times normal limits. Now, what we don't have is any previous urinase available at the time to identify, is this a new kidney abnormality, or has been going on for a while, and is it progressively getting worse? His sodium and his potassium, which were also checked, were completely normal. His full blood count was normal. His liver function was normal, bone profile normal, CRP normal. And that was in the checks from the general practitioner. But he was sent to the ambulatory care unit, the same day emergency care unit, because of these abnormal urinase. And he came to see me and took a history, didn't really again have anything wrong with him. He said, I don't know why I'm here, doctor. They always say that. I don't know why I'm here, doc. Feel absolutely fine, absolutely fine. And then key things, like you said, when you've got somebody who's got an abnormal kidney function, and on further questioning a rash, you start to think about skin kidney issues. So what else would you like to know in this history of this man who presented?
Okay. So we've got his past medical history of hypertension, for which he takes an ACE inhibitor of some description. And he feels fit and well, and his remaining blood work is normal, save for his user needs, which was revealed as a urea of 20, which is sort of 3 times the upper limit of normal, and a creatinine of 300, which is 3 times the upper limit of normal. And then there's a rash. Can I just get some info about the rash, please?
Yeah, so the rash is on his lower legs. He doesn't know how long this rash has been there for. Can't tell me. It's itchy. And his skin feels a little bit dry. But apart from that, nothing significant of note. It's on both legs and it starts just underneath the knee, the kneecap, the patella.
Is it painful?
Not really.
Okay. And it doesn't extend up to his buttocks or anything like that?
No.
Okay.
No. It's definitely on the lower leg.
Okay. So we've got here a guy who's either in very severe AKI or acute kidney injury, or he's someone who's got really quite bad CKD for his age, which has only just been diagnosed for the first time. If he was in acute kidney injury, I'd imagine he'd feel unwell. For example, if this creatinine had gone from normal to 300 over a period of days, I think he'd feel very unwell. He'd feel a bit uremic as well. So I wonder if he's been building up to this over a period of weeks, if not months, this kind of renal function. So I think that in terms of seeing him in the ambulatory care clinic is probably appropriate, because you don't know if you've just made a new diagnosis of a very chronic disease. When I wonder if someone's got chronic versus kidney disease, I do look at the HB, and because it tends to go down when it's CKD, although that's not diagnostic, it's just when I'm adducing all the information. I tend to look at the phosphate, that tends to go up in CKD, but again, it's not a diagnostic test. But you're telling me everything was normal? Completely
normal. Okay. And he was literally bouncing around the unit, and you see these patients that look so well. And just really, really chatty, very well guy, chatting to everybody, walk in the unit, as you know.
Okay. So looking at the renal function, if we're going to assume worst case scenario now and say, oh my gosh, it's an AKI, then is it pre, intra, or post-renal? If it was pre-renal AKI, i.e. kidney hypoperfusion, you would have picked up on hypovolemia, and you're telling me he looks too well for that. So I don't think this is someone who we can just say, pop in a cannula and bung him some fluids and then check the renal function in the morning. I think that would be a case of what we call premature closure, i.e. you stopped thinking a bit too soon there. Post-renal, I definitely would get imaging of the renal tract, because he could be in chronic obstruction. He's the right age to have prostatism and be generally retaining urine. And if he's got bilateral hydronephrosis, that could be a diagnosis here. And the rash could be something else. So he does need an ultrasound KUB. Or a CT KUB, whatever is your unit's favorite. But I'm thinking more about intrarenal causes of what could be going on here. Because he's got this rash. So could this be a vasculitis / glomerulonephritis picture? So I would like to see a urine dip, a nice EC bedside test to see if he's got nephritis or nephritic syndrome. Do you have that information?
Yeah. So urine dipstick was clear, normal.
Okay.
So there was no blood.
Yeah.
There was no protein.
Yeah.
And looking at it macroscopically as well, it wasn't frothy.
Yeah.
And there wasn't any macroscopic hematuria that was picked up. There was no glucose in it. And there was no nitrites either, indicative of infection.
Okay. And you're saying that his serum albumin was normal, so he's not nephrotic anyway, and he hasn't got pitting edema or anything like that.
No. I mean, he really does look unwell, man.
Okay. I think at this point I would do my general kidney badness screen, which would be getting a serum CK, I know he's got a bland urine, but I still would get a vasculitic screen, which would be autoantibodies and an ESR. And I would be looking at the rash if I was looking at it, it wasn't a pattern I recognized, then I'd be thinking about asking our dermatology colleagues to see if they could have a look at it, and whether or not a punch biopsy would be of any use, whether they could diagnose straight off the bat. Also immunoglobulins as part of my kidney screen.
Looking for myeloma, was that?
Looking for myeloma, yeah. And I also would just ask the patient, he didn't have any sort of preceding illness, like a viral illness or COVID or a sore throat or anything, or a fever that could have set this off in the preceding weeks.
Nothing. Nothing that he remembers. And actually, when you do his observations, so as part of your examination, you do an obs, and his blood pressure's slightly elevated at 150 over 95, but he's hypertensive. His oxygen saturations are normal. He's aporexial. Pulse oximetry is normal. His temperatures is aporexial. It's all normal.
Gosh, so I'd be waiting for those bloods to come back, which do take a bit of time. I'd be examining him head to toe. I'd be looking for any signs of fluid overload. I'd be looking for any cardiac murmurs, any signs of endocarditis, but that's unusual. I'd be looking at his fingers. I would be listening for renal bruise. Has been starting ramipril caused, he's got renal artery stenosis, and that's triggered it. And I'd be feeling his abdomen for any organomegaly, checking his peripheral pulses as he got vasculopathy. I'd be doing a full examination. But are you going to tell me that it was completely normal as well?
I am.
Okay.
So I'm going to throw in something here. So I saw this gentleman and did pretty much what you said. So took a history, did an examination, and took some blood tests. Now, because of my rheumatology background, I automatically, as you mentioned straight away at the beginning, actually went, oh my word, this man must have vasculitis, and it must be granulomatosis with polyangiitis. It must be
granulomatosis with polyangiitis,
GPA.
Yeah, GPA, formerly known as Reagan as well. Is that right?
Absolutely. Yeah. So this man clearly has a small vessel vasculitis, because he must have. Because I was a rheumatology trainee. Genuinely. Yeah. So what was I doing? What cognitive biases was I using there? So, and I remember this. This is a really embarrassing case for me, and I remember it so well because of what I did next. So because I was a rheumatology trainee, and because I did see, obviously, a very hand-picked selection of patients who did present with abnormal kidney function and a rash, and it was often vasculitis, because they'd already been screened, they'd come to me often with a diagnosis. So I was I was overconfident. I also had that typical sort of availability bias, in that before I changed into acute medicine, a lot of the patients I was seeing did have vascular disease, and therefore it was available at the forefront of my mind. So as soon as somebody came in with that typical puzzle, it must be vasculitis. I could not see any other diagnosis at all. I just couldn't see it. And I was like, right. And even though this man was on, I was like, right, we've got to admit you. You've got to stay on the ward, and I've got to do all of these fancy tests. Now, you couldn't get an ANCA test done in this hospital, because it just wasn't possible at the time. It was quite a small district general hospital. And this man clearly had vasculitis, which was going to need, intravenous steroids and cyclophosphamide or whatever. So please don't judge me. I was a junior registrar at this point in acute medicine, and the only hospital that could do an urgent ANCA level, which would clinch the diagnosis for me, was 55 miles away. They agreed to do the test, and the lab where I was working agreed to pay for a taxi, and I taxied his bloods to the hospital to get these ANCA levels done.
How long did that take to organise?
Oh, well, I mean, when I want something doing, I can be really forthcoming. Wow. And it was done that afternoon.
Gosh.
Well the done. Taxi was arranged that afternoon anyway.
Yeah.
And so I took this man's bloods, told him he probably had this really rare condition, and that we needed to do these urgent blood tests, got them in a taxi, took them to the regional centre of excellence for vasculitis to do this urgent blood test. Embarrassing. I cannot believe I did that, but I was so convinced that this is what this man had. I could not see any other diagnosis. What do you think his anchor was? Positive or negative?
Well, my sense of narrative tells me it's going to be negative. That doesn't come from a clinical acumen. That comes from how you're telling the story.
I mean, you can get anchor negative vascular disease. They do exist. However, that's not a diagnosis I should really be making in the ambulatory care unit.
So can I ask a clinical question?
Yeah, of course.
So you get vasculitis, which affects the kidneys, and you would still get a bland urine dip in that case?
No.
You wouldn't get oh, okay. So what did you? So the information about the normal urine dip, you managed to subconsciously eliminate that from the reasoning process.
Yeah.
Wow. Yeah. Okay. Yeah, I get it now. Yeah. So you're talking about the availability heuristic or the availability bias,
Absolutely.
which is the biggest diagnosis in your mind, usually based on recent cases, is the one that you want to rule out first, rather than other causes. Okay. And it's actually very powerful because it leads you to rule in information which supports your diagnosis and rule out information which goes against it, so you can force it to fit. And I see that quite a lot. I work in a very big tertiary center with lots of a big central hospital with lots and lots of specialists, and I, as a generalist, I see people picking up the pieces of the clinical story that fits what their specialty would do and putting down the bits that doesn't. And I'm not going to finger point any particular specialty. I see it in all directions. And when you say, but what about this aspect of the story? You do get a bit of, yeah, but you that's like atypical, but it could still be. And it's interesting to see from the outside.
I mean, I learned a huge amount from that case about myself and how I think, actually, because I was so embarrassing. I told, when I think about it, I got this anchor level done, even though it's CLP, ESR, urine dip, all normal, chest x-ray normal. The rash that he had was typical of varicose eczema.
Right.
Okay. However, to me, that rash must be, a vasculitic rash. And, and I think it was also a point of proving to, proving to those who I was working with that I was a rheumatology trainee. I'd changed into acute medicine, but I could still do rheumatology. And then actually, I'm really cool because I can make these diagnoses, just on the hoof.
Wow.
I couldn't actually. I just made a fool of myself. And actually, the patient did not have a vasculitis. He had peripheral vascular disease. Because he was a smoker, he was a bit hypertensive, and he had some chronic kidney disease.
Okay.
But I just completely jumped in with 2 feet.
I think just to give a slight rebuttal, I think he did need those tests probably doing. I would think so. I mean, as I said, I would have done the vasculitis screen myself at that point because and I guess for me, the bias I'm there is that people who tend to have CKD to level of a baseline creatinine of 300 tend not to look so well. Yeah. They're slightly not frail, but they're sort of they're not as well. There's not as well. So I think at that point, if the patient was swearing blind to me, they were the picture of health, I would be looking for something else rather than, and I think it would be a little bit premature to say it's probably CKD without doing a proper kidney workup.
Okay.
Whether I wouldn't have couriered the bloods over that day to the next hospital because it wouldn't have occurred to me that was an option, but I would have actually requested the blood tests.
Oh dear.
Yeah, I think it's interesting, and it's not unusual nowadays for trainees to switch specialties.
Yes.
In acute medicine, we get a lot of trainees from different disciplines rotating through the department: GP trainees, anaesthetic trainees, internal medicine trainees, foundation trainees. And I've seen, we've had GP trainees who were previously ST5s neurosurgeons, and they decided to completely switch it up. I've had IMTs who were previously psychiatrists who wanted to come back to internal medicine. And I think it's getting more and more common. And within medical education, which we both are, I think part of our role is to support people who say, I think I'm coming up to a very big decision here. And it's not an easy decision to make, because as much as we like to say about flattened hierarchy, there is something going down, busting down a few grades from, say, I'm an ST5 or 6 rheumatologist, now I'm an ST3 acute medic or whatever specialty. there's still a sense that you've taken steps backwards, even though you haven't, you've sidestepped, but you feel as if you dropped a few rings, and maybe you will feel like you have something strong to prove to
and
people.
That's what it was. I felt like I had something to prove, that I was worthy of working in acute medicine, I guess. And it was, I mean, I learned a lot. And I remember the doctor and his name, who I was with on that ward round that day. And I think for the first time, he was like, oh my God, she's like this guru. And then the next day was like, oh my word, what did she do? You know?
Do you think it was the first time that in acute medicine you had been shown the respect you thought you had, you deserved it? Is that what it was? Like, people were impressed?
Yes.
Okay.
I think so. I think it was, you know, I'd nearly finished rheumatology and I was going back to acute medicine. Yeah, I think it was about respect. I think it was about appearing clever.
Yes.
I think it was about looking like house. It was a lot about ego. I mean, this was a few years ago now, and I've definitely changed. I'm not like that anymore. But at the time, I was proving to myself and others that I could be there, and I was valid to be there, definitely.
I think it took me a long time after I was a consultant to say, I don't know. And to say, absolutely. I've got no idea, because I was under the impression that consultants were supposed to know everything. It even took me a long time to say, as a consultant, say to my trainee doctor, saying, I don't know, let's look it up, and getting up to date on the system, or BMJ best practice or something like that, saying, I don't know what the latest guidance are, let's do it together, because I felt like maybe I was supposed to know this and be teaching them. And it actually took a while for that to settle down. I think a lot of new consultants describe the same phenomenon, which is probably linked a bit to imposter syndrome, and self-esteem, and what we perceive historically a consultant to be. And it took a while to reframe in my brain that a consultant isn't someone who knows everything, but it's a consultant who knows kind of how to make a plan in situations. And that's sort of linked in with leadership, I guess.
And also know what you don't know. Because then I didn't know what I didn't know. And I could not admit when I didn't know what was going on. I had to have a diagnosis. And like you say, that's changed now. I mean, I'm happily talk about diagnostic uncertainty, and I'll tell the patient no when I don't know what's going on. But then I just couldn't do it, because it was admitting that I felt like I was admitting that I was a rubbish doctor, actually. And it took a big medical mistake that I made after this case within the same place for me to completely change my way of thinking.
When you talk to patients and you're telling them you don't know something, how do you phrase that?
So I often use chest pain so for example, if I've got something like chest pain, I'll say, so at the moment, you've got chest pain. Now, I know that your chest pain is not caused by a heart attack. We've managed to rule that out. We've done the blood tests and we've done the investigations. I've looked at the heart tracing. However, what I don't know is what the cause of the chest pain is. So I'm happy to say that it isn't this, but I don't know what it is. Chest pain can be caused by many, many different things, serious and non-serious. I'm happy that we've ruled the serious causes of chest pain out in yourself, but I just don't know what it is at the moment. And sometimes we don't know. And I think what we need to do in this situation is watch and wait. I'm happy to send you home. However, these are the things to look out, the red flags. If these happen, please come back. Let's watch and wait, and let's see what happens over the next few days or weeks.
Yeah, that's good.
And patients are really receptive to me saying, actually, I just don't know what it is.
Yeah.
Because what I don't want to do is say, oh, it's reflux, or it's
costochondritis.
Costochondritis, it's non-cardiac chest pain. What even is that? Because then you're medicalizing them. And you're giving them a diagnosis.
Yeah, that's a good point. I often feel like a consultation has not completed until I've come to a diagnosis. And also it's quicker. It's quicker to say, hello, Mrs. So-and-so, your diagnosis is X. Here's a bit of info about it, and here's what to expect, and goodbye. And it takes longer to say, okay, now we have to have a chat and have the conversation you just had. And also, I think we feel patients are more satisfied with a name. because it's always better to name the beast. And I think we sometimes worry that patients are going to struggle if we don't name what's going on. But as you say, patients are actually open to knowing what the serious stuff could be and having ruled that out in taking a more of a watchful way. But some aren't, and some will push back on that. But I think the majority are happy just to know that we've thought and we've put a bit of thought in, and we haven't said negative ECG, negative trop, negative X-ray, see you later. They've actually, we've run it through our brain and said, here's how I've come to the conclusion. I don't know what it is, but I know what it isn't. And that's very reassuring. Yeah. And that takes a conversation.
And, when I do have people push back to me and say, well, what is it then? You said what it is. And I'll say, well, I really don't know. And I often say, I don't want to give you a diagnosis when I'm not 100% sure. Yeah. I mean, you're never 100% sure in medicine, but I don't want to give you a diagnosis because that would be wrong of me to do that. And sometimes if a patient I'll say, I'm going to go and talk to a colleague, actually. I'm going to go and get a second opinion then. And I've done this with chest pain. I've done it with headaches that I'm unsure about. And I'll say, I'm going to go and talk to another consultant. And I will often, on occasions, I've got the other consultant to see the patient as well.
Right.
And I guess
that relies on availability of colleagues, isn't it?
Yeah, that is a challenge. And also it's who you're on with, in the day. So if I've got a good critical friend at work, not a friend who criticizes me, but I mean a critical professional friend who will look at it and go, have you thought about this? Have you thought about that? And I'll be like, oh, actually, I haven't, no. And I find that quite helpful. Again, that can be time consuming for both parties and also availability. But if you have one of those days where you may have that, it's good learning as well, I think.
And we're always learning. And
Every
I think
day's a school day.
It's very important to emphasize that as for incoming consultants and for any other trainees saying that we're also learning. And there is a myth that I do know a couple of consultants who I'm convinced do know everything, but I think most consultants, the only thing I've got over a trainee is I've seen more cases. That's the only thing I've got that they haven't. They've got more clinical knowledge than me, because you pit me against someone who's just done their PACES exam. They're gonna, they know way more than I do about the intricacies of clinical medicine. The only thing that I've got they haven't is I've probably seen more patients over a period of time frame, and therefore more wrinkles. But otherwise, that's it. So that just puts more experiences in the bank that I can draw from. I keep talking about gut. What is gut feeling? Gut is just clinical experience in the bank, which you're using to sort of cross-reference your current clinical encounter with. But sometimes that comes up with nothing, and I've got to either ask someone for help, and that could be one of my own trainees. Say, hey, you've just done PACES, remind me, what should I be doing in this? Or you're one of my registrars, you're a neurology trainee, thank God you're on call today, come and tell me about this. Or they ringing the gastro reg and saying, what should we do now? And I think if I'd been a very much younger doctor, I would have found that strange. Why is a consultant asking a more junior, i.e. a trainee, for assistance here? But that's how cross-specialty working works. And yes, I have to make the decisions and sort of my name's above the patient's bed, but I don't do that based on my own massive pulsating genius. I do it because I'm seeking opinions and guidance on people who know more stuff than me in certain other areas. And that's sort of why I love acute medicine, why I love generalism, because I get to see the lot. You do see some cool vasculitic stuff coming through, and you do see someone with an incidental finding of new CKD and everything in between. And the fun part of I think generalism is that scope and being able to apply your sort of clinical detective principles and calling on colleagues who know different parts to different areas to help you reach the diagnosis with the patient. Yeah,
and I think part of the genius or the consultant role is recognizing when you need help. You've had experience in clinical reasoning, which you haven't got as a first year medical reg, or you've got a little bit but not much, and I think it's a lot of it is experiential as a consultant, and what you've seen, what you haven't seen, and also what previous specialty did you train in. So again, even as a consultant, I still now overdiagnose inflammatory arthritis, and gout and all those sort of things, because that's what I'm used to seeing. That's what I saw for years in clinics. You know, when I did my 5 rheumatology clinics a week, I did see the new inflammatory arthropathies. I did see gout a lot. But again, on a positive spin, I do pick up gout that maybe has been diagnosed as something else when actually it is gout. So, you know, I think my rheumatology experience has stood me well. Maybe not in the case where I couried the bloods over to you know, but anyway, that was you live and learn, don't you?
I bet it has done you well. I think it's great to have rheumatology experience anywhere near acute medicine, and AMU or acute medical.
Absolutely, yeah, absolutely. And one of my colleagues I work with is a rheumatologist, but does a day in our medical decisions unit a week. Because the knowledge of a rheumatologist is so generally medical, because obviously rheumatological conditions affect the whole body. So
I remember when I was training, and I met a colleague who was a rheumatologist, and I said, why do you like rheumatology? She said, oh, because it's general medicine. It's the only true general medical specialty. And I sort of choked on my tea. It's like, oh, okay. Yeah, it is general medicine, the only general medicine. Hi, I'm an acute medic.
That's really interesting, because that is really why I went into rheumatology initially, because at the time, I think acute medicine was really early in its infancy, and rheumatology seemed very general medical, and I knew I probably didn't want to go down the geriatric route or endocrine route, so I did rheumatology, and it was very general medicine. And then I was doing acute medicine shifts as a med-reg. I was like, oh, okay, then so this is where I should be. But I think acute medicine training, I think I was one of the first or second years when I started my room training. Acute medicine was really coming into its
careful, because you're going to give away your age in a minute if you.
I know, that's true.
But no, I know what you mean. They established the first acute medicine unit. I was training in Newcastle, and they opened the first one, and it was like an experiment. Acute medicine was a new specialty, and I got a CMT job in acute medicine, and that's when I had that sort of come to Jesus moment. I was like, oh, I found my specialty. I love the take. This is really good fun. I love this, and that's how I found it. But you know, if I'd been training maybe 5 years earlier, I wonder where I would have ended up, because acute medicine didn't exist.
That's really interesting, isn't it? Because that's what exactly happened to me. I remember doing acute medicine on calls with a fantastic acute physician. I was like, oh, this exists. It was like I'd found my role, my place.
Me too.
Oh,
aren't we lucky?
We are, exactly. I know. Fab. I mean, there was so many learning points in that case. I think.
How would you summarize? Give me a couple of bullet point learning points.
Number 1, be aware of your own biases. So in this situation, I wasn't aware of my own biases. And this was, a while ago, but be aware of availability heuristics, be aware of confirmation bias, be aware of hindsight bias. And when you are seeing patients and making a diagnosis, think, am I utilizing my biases correctly? Definitely. Number 2, patients can have as many diseases as they damn well please. I say this all the time, good old Hickam. But this gentleman, I was trying to fit a puzzle together of the rash and the kidney disease. It must be vasculitis. Well, actually, he had chronic renal failure and peripheral vascular disease. So, sometimes a picture doesn't have to be a unifying diagnosis. It can be. And actually, multimorbidity is one of the things that we see more and more, isn't it? Patients have so many conditions now. And also, I think, if you've got somebody who does have a rash and abnormal U's, think about vasculitis, but it doesn't have to be a number 1 diagnosis, okay? And actually, you can work through your investigations. So full blood count, is it normal? Yes. Is vasculitis possible? Okay, maybe not. Urine dip, normal. Okay, do I actually even need to do that anchor level? Again, up for debate. You'll speak to lots of different physicians who will have lots of different opinions. Also, there is no right answer and there is no wrong answer. We are in between, aren't we, I think?
Yeah, we live in ambiguity.
Absolutely. We live in diagnostic uncertainty. Yeah. And interestingly, the GMC, I was reading something on the General Medical Council website, and for anybody who's starting medicine in the UK, wants to practice medicine in the UK within the next few years, they're going to have to take the medical licensing assessment. And as part of that, number 2 is being able to live with diagnostic uncertainty. And I think that's really interesting, is that that's now coming into our curriculum.
And I find that that's more difficult the less experienced you are, i.e., I mean, I've been on ward rounds where I've seen foundation doctors actually get quite frustrated, saying, but what is going on? I don't understand. What do I write here where it says impression on your ward round? And I'm like, right, I don't know. Right, I don't know. Could be 1, 2, or 3. Differential is this. And tolerating that uncertainty. But I've seen it actually rile people up. They don't know what is the answer. And you have to be able to sit well with that, saying, okay, we don't know. And, I've even seen cases where we never knew. And you have to sort of be okay with that and say, I don't know. I always say this to new med reggers who panic about how am I going to run the take overnight without a consultant around. And I said, you don't have to know everything. Just you have to know this direction of travel for the next few hours. How do I keep the patient safe? And you're allowed to say to anyone, to ED, to your own doctor, say, I have no idea what's going on with this patient, but let's correct the blood pressure. Let's correct this sodium level, and let's correct this. And then we'll see them in the morning and see what's declared itself. And that is absolutely fine. And that is actually the mark of a really good clinical leadership. Even if you don't know what the answer, inverted commas, is, you kind of still know what to do. Yeah.
And I think what we don't have a lot of in medicine, but we don't use enough of, is time and watching and waiting.
Vitamin T, I call it.
Vitamin T. Oh, I like that.
Yeah.
Vitamin T.
They say, what does a patient need? I say, they just need a bit of vitamin T. We just need to observe them for, I think in 2 or 3 days, we'll know what's going on here.
I'm going to use that as well, vitamin T. I love that. So I think it's like, you've got your differential diagnosis list. And what I'll often say to the juniors is, so why could it be this? And why couldn't it be this? And work through them rather than making that, trying to get to that diagnosis.
Yeah, don't force it.
No, absolutely. And if in doubt, courier a taxi to take over.
Just courier the patient. Say to the patient, go to that hospital. They'll look after you. Please
don't courier taxis. I can't believe I did that, but I did. And, you live and learn, don't you?
At least you didn't pay for it.
No, that's true. Yeah. No, that's true. Okay, what's your one takeaway message then for today?
I really liked what you said about tolerating uncertainty and being able to signal that and broadcast that to your team, especially from a senior leadership role, and being able to role model it really and saying, I don't know what's going on, but I know how to keep this patient safe for now. I know how to correct the correctable. I think that's really, really useful. And I think it's very useful for more junior colleagues to see that in senior sort of leadership roles, to know that they're not obliged to always know exactly what is going on, especially in the first few hours of the patient's inpatient journey.
Absolutely. It's about seeing uncertainty in action and watching it. And it's role modeling, isn't it? Definitely. Fab. That was a really interesting discussion. Thank you very much, Ben.
Thank you for having me again. It's always great fun.
It's honestly absolutely my pleasure. And I look forward to seeing these shelves of yours whenever they appear.
The bookshelves. Keep your eye on Twitter. They will appear.
Yes. Fantastic. Thank you so much for joining me again today. Thank you to everybody for listening. All you listeners out there, please review the podcast, because the more people that review it, the more people that will be aware of the podcast. Thank you for listening to everybody. And if anybody's got any good cases they want to share with us, please get in touch at Amie Burbridge. Thanks for listening. Goodbye.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.